So we are finished up with acute inflammation, and the process, the vascular and the cellular events, that is the most important area that I need to focus on. Okay, and if you talk about the chronic inflammation, now the reasons are that they can be persistent infection, hypersensitivity diseases, or toxic agents. These are the chronic. Why do the acute ones get converted to chronic? Because of all these points. Now, morphological features, obviously there is infiltration with the mononuclear cells, tissue destruction, attempts at healing will cause the connective tissue replacement by angiogenesis and fibrosis. So yes, now the role of macrophages, as I was talking about. So see, the dominant cell in the most chronic inflammatory reactions is the macrophages, which secrete the cytokines and growth factors that act on the various cells, destroying foreign invaders and tissues and activating other cells, notably the T lymphocytes. So these T lymphocytes and macrophages are, activated by each other. So this is a very important interaction happening over here. Okay. These macrophages have got several names in several areas, like liver, you have Kupper cells, spleen and lymph nodes, you have the sinus histiocytes, CNS microglial cells, and lungs, you have the alveolar macrophages. In the reticular endothelial system, you have the mononuclear phagocyte system. So these have different names in various areas. So what happens is the products of this activated macrophages, they will eliminate the injurious agents such as the microbes and initiate the process of repair. And that is why they are responsible for the chronic inflammation. So yes, this is now, this macrophages will ingest and eliminate the microbes. It will also play an important role in the tissue repair and scar formation and fibrosis. It will secrete the mediators of inflammation like TNF and interleukin-1. So macrophages will secrete TNF and interleukin-1, and they will display this antigen. They will present this antigen to the T lymphocytes, and they will respond to signals from the T lymphocytes called as the cell-mediated immune response. So they also have interaction with that. Now, there are two pathways of macrophage activation. Number one is the classical, and number two is the alternative pathway. A very important point to remember and understand here is that, see, number one is the classically activated macrophage, which is the M1, and M2 is the alternatively activated macrophages. Obviously, I will discuss about the mechanism, but the point to remember here is that the classically activated macrophage, or the M1, has a role to play in inflammation, but this M2, or the alternatively activated macrophages, they have an anti-inflammatory effect. So both of these effects are completely opposite. In the cases of M1, it will get activated by this microbial product, especially the interferon gamma. So once it gets activated, there will be release of ROS, NO, and lysosomal enzymes, which will have the microbicidal actions, means phagocytosis and all of this, and interleukin 1, 12, and 23, which will be playing an important role in inflammation. Okay, and the M2 will get activated by interleukin 13 and 4, which will ultimately lead to the TGF beta formation, which plays an important role in tissue repair and fibrosis, and the interleukin 10 and TGF beta, which has the anti-inflammatory effect. So this is what is mentioned over here. This diagram is again very important, and this point I've mentioned, all of these are important. These interleukins are also important. You don't know, somewhere or the other you may get questions linked with this. So what is basically the role of the lymphocytes? So microbes and other environmental antigens, they activate the T and B lymphocytes, which amplify and propagate the chronic inflammation. So you can see here that there is an interaction, as I've mentioned before, that there's a macrophage lymphocyte interaction in the chronic inflammation. The activated T cells produce cytokines that recruit the macrophages. So what is that cytokine that recruit these macrophages, which is produced by the T lymphocyte? It is the tumor necrosis factor and the interleukin 17. So this TNF and interleukin 17, which is produced by the T cells, will recruit the macrophages, and now this activated macrophages will in turn stimulate the T cells by cytokines, which is interleukin 12. So this interaction is very important. Don't look at this image much, you may get confused here, but this word and these sentences are very important. You will not get confused if you read this. Okay, and this is the typical formation of a granuloma. As I said, this interaction of macrophage and lymphocyte ultimately leads to the formation of a granuloma, and it's a very important and good image you can see here. So the you have to understand, I have also told you now what is, how does this thing happen. So I've mentioned here that with this activated T cell will produce TNF alpha and interleukin 17, which will recruit the macrophages, and now this activated macrophages in turn will stimulate the T cells via interleukin 12, and this interaction will form the granuloma. The different kinds of granuloma, just a brush up: non-caseating granuloma seen in these conditions, caseating seen in these conditions, foreign body granuloma. Very important, in the foreign body granuloma there is absence of T cell mediated response. Very very important concept. Okay, in your MCQ, important concept that foreign body granuloma does not have any T cell mediated response. Immune granuloma, they will have the cell mediated response, and the stellate granuloma. So here I want to also mention to you what is the mechanism of formation of granuloma. So first, the antigen is taken up by the macrophage and is presented to the to the CD4 plus helper T cells. So first, this antigen is presented to the CD4 plus helper T cell by the macrophages. This CD4 plus helper T cell will now convert to the Th1 subtype. Once it gets converted, it gets specialized into this Th1 subtype. Why? Because you can see that this CD4 plus T cells, they have three sets of they have three subsets, right? Number one is the Th1 subset, Th2 and Th17. So Th1 will produce the cytokine interferon gamma, which activates the macrophage in the classical pathway. Very important. Th2 will secrete interferon 4, interleukin 4, 5 and 13, which will also recruit the eosinophils and activate the macrophage by the alternate pathway. Very important. And Th17 will secrete the interleukin 17, which will induce these cytokines or the chemokines. So again, very important. All these points are very very important, and Th2 is implicated in the helminthic reactions or the allergic reaction. That is why they are recruiting the eosinophils here. Very very important. यू अंडरस्टैंड, सी ईओसिनोफिल्स के साथ में TH2 ही हमेशा आएगा. सो इसके साथ इसका कनेक्शन है. सो दिस काइंड ऑफ कनेक्शंस आर बेसिकली आस्क्ड एज कॉन्सेप्ट्स थ्रू द MCQ. So I was talking about the fact that Th1 is a subset of CD4. So now coming back to this CD4 will get converted to the Th1 subtype and not the others. Okay, so this Th1 will now secrete interleukin 2 and interferon gamma, okay, which will activate the macrophage. And now when this macrophage is activated, this macrophage and the T cells will further secrete TNF alpha, and all this interaction will ultimately form the granuloma. So this is just a basic understanding. The various kinds of multinuclear giant cells, such as made a list here, you can go through this. Foreign body Langhans, you can see in foreign body the nucleus is scattered, but in Langhans it is arranged in a horseshoe shaped manner. You can see here like this. Then Taunton, anaplastic and osteoclastic is just the names you have to remember, because sometimes you get questions that what are different kinds of multinuclear giant cells. So this is the answer to that question. Okay, so that is how the interaction happens, and all of these are easy to remember. So eosinophils, they have granules that contain the major basic protein. Okay, again an important question, and it is toxic to the helminths. Now mast cells, again they kind of act as they express their on the surface the receptor which binds the FC portion. So all this I've explained. Now coming to the granulomatous inflammation, this is a very very important question. Okay, whatever you exam you appear for, this question some way or the other will be asked to you. So it's a form of chronic inflammation characterized by collections of activated macrophages, often with the T lymphocyte and sometimes associated with the necrosis. And these different kinds of granuloma I've already mentioned in that list before. So what happens is you have to draw a diagram here, and these activated macrophages, they have this pink granular cytoplasm, and they are called the epithelioid cells, which are present in the surrounding in the collar of the necrosis. So in the center you have one necrotic area, or maybe caseous or non-caseating, whatever it is, which is surrounded by these epithelioid cells. And beyond this epithelial cell, there's again a collar of lymphocytes. Okay, and beyond this lymphocyte collar, they can be arranged by a rim of fibroblasts and connective tissue. Okay, and also you may get multinucleated, obviously you will get multinucleated giant cells present over here, mainly the Langhans giant cell. So all these points are important, and this is a very very important question, short note jo bhi aap keh lo. So you can see these are the Langhans giant cells. You can see this is this is having a horseshoe shaped pattern. Again, an important point to understand, this is a Langhans giant cell. It is, the word is Langhans, okay? The word is not Langerhans, okay? This is again a confusion, so don't make this mistake. ओके, केसीएस नेक्रोसिस के बारे में ज़्यादा कुछ कहने की ज़रूरत नहीं है. So this is it. Now, what are the systemic effects? Obviously, there's going to be fever because of this interleukin 1 and TNF alpha. Arise in the acute phase reactants. These are the acute phase reactions. You can just go through the names, leukocytosis, and all of this. So that is what it is. And now, if you talk about the tissue repair, this is another important part which you need to understand. That's tissue repair. Now, repair, known as healing, refers to restoration of the tissue architecture and function after an injury. And this repair, they occurs by two processes. Number one is the regeneration, and number two is the scarring. So what is the difference between them? Regeneration means there is restoration of the normal cells. Whatever the kind of cell and tissue was there, it is coming back. That is why it is called regeneration. So repair may be regeneration, maybe scarring. But once the scarring, there is no restoration of the normal tissue type. There is deposition of this connective tissue. That is why it is called as scarring. Okay? So regeneration में क्या होता है? You know that there is proliferation of the differentiated cells that survive the injury and retain the capacity to proliferate, like the hepatocytes in the liver. But in case of scar formation, there is the tissues which are incapable of regeneration, or they are too severely damaged, then the repair will occur by laying of the connective fibrous tissue, which will result in the scar formation. The term fibrosis is often used to describe the deposition of collagen that occurs in the liver, lung, kidney, and other organs as a consequence of chronic inflammation. And if this fibrosis develops in a tissue space occupied by inflammatory exudate, it is called as organization. Okay? So you can see here, if it is a regeneration, you can see the cells are becoming normal. But if it is a scar formation, you can see that there is collagen deposition. So what are the the ability of the tissues to repair themselves is determined by their intrinsic capacity, and there are three kinds of, based on whether they can regenerate or not. If you talk about the labile or continuously dividing cells, they are continuously being lost and continuously being replaced by maturation of the tissues and by proliferation, like the hematopoietic stem cells. Okay? Number two is the stable cells, which are quiescent and they have only minimal proliferative activity. So they can't regenerate, they can minimally regenerate. Okay? But permanent tissues, they will never regenerate, like the neurons and the cardiac muscles, and therefore these tissues will always have a scar. Okay? Now, repair by connective tissue deposition. So yes, if the repair cannot be accomplished by regeneration alone, then obviously the replacement of the injured tissue with connective tissue will be there, which will lead to formation of a scar. So what are the steps in scar formation? First, there is inflammation, recruitment of the neutrophils, and then the monocytes. Number two is the cell proliferation. So there's going to be proliferation of all these cells, which takes up to 10 days. These numbers and timelines, wherever you see, are important questions. Okay? So what kind of cell plays a role here? That is the epithelial cell, endothelial cells, fibroblasts, which proliferate and migrate. So these epithelial cells will respond to locally produced growth factors. Endothelial cells, pericytes, they will proliferate to form angiogenesis. Fibroblasts will proliferate and migrate to lay down the collagen. Finally, there's going to be formation of the granulation tissue. Okay, and this granulation tissue will ultimately get stabilized after the angiogenesis process. Then there's going to be deposition of the connective tissue. This granulation tissue is progressively replaced by the collagen. The amount of connective tissue increases in the granulation tissue, and then there's a stable fibrous scar formation, because now the collagen percentage is the highest. Okay? So macrophages play a central role in repair by clearing the offending agents and by providing the growth factors and secreting the cytokines, which stimulate the fibroblast proliferation, because we know that collagen deposition is the utmost most important part in scar formation. So the next important point is the angiogenesis. In granulation tissue, you do have this this process going on, which is angiogenesis, which is the process of formation of new blood vessels from the existing ones. Now this method or these steps are also important, sometimes asked as short note. The first is vasodilation, next is separation of the pericytes, then migration of the endothelial cells towards the site of the injury, proliferation of the endothelial cells, recruitment of the periendothelial cells, and suppression of the endothelial proliferation. So these are just the points which help in the process of angiogenesis. So you can see here that the VEGF promotes vasodilation by stimulating the NO production, okay? And these fibroblast growth factors will proliferate the endothelial cells. They also promote the migration of the macrophages and fibroblasts to the damaged area and stimulate the epithelial cell migration to cover the epidermal wounds, okay? These are the angiopoietins and the growth factors which play an important role in angiogenesis and the maturation of these new blood vessels. These growth factors will also participate in the stabilization processes. The notch signaling pathway will also help in sprouting of these new vessels, which will ensure that these vessels are formed to have proper spacing, okay? Now these ECM proteins will also participate in the process of vessel sprouting. As you can see, there's vessel sprouting here. So this is a very, very important diagram. Again, the formation of angiogenesis in the tissue repair. The angiogenesis mainly occurs by sprouting of the new vessels. As you can see, the newly formed vessels will join up with the other vessels to form a new vascular bed. And all these steps you want to mention, and whatever points I've highlighted, all of which you can just mention, and there's nothing much to understand here. It is just that these kind of factors come into play, and there's formation of new kind of sprouting vessels which ultimately form the vessel bed, which is the outcome of the angiogenesis process, okay? All of this, that means the extracellular matrix, these growth factors, the notch signaling pathway, TGF beta, all of this endothelial proliferation, all this plays a simultaneous combined role in the process of angiogenesis. Now if you talk about the deposition of the connective tissue, the laying down of the connective tissue occurs in two steps: migration and proliferation of fibroblasts into the site of injury and deposition of ECM proteins produced by these cells. That means the major sources of these are the inflammatory cells, which is particularly of the M2 type. TGF beta is the most important cytokine for the synthesis and deposition of connective tissue protein in the scar formation. So this is again a very, very important MCQ. In the connective tissue, or rather in the scar formation, is the TGF beta, which is the most important molecule, okay? Now remodeling, that is not that important. The factors you can just go through it. Now healing, yes, healing by first intention and second intention, this again comes as a long answer question or a short note. So you must understand these, again these timelines are very, very important. So if you talk about the healing by first intention, it only involves the epithelial layer. So when there is an injury to only the epithelial layer, there is epithelial regeneration which is getting healed by first intention, especially in case of a clean uninfected surgical incision. The wounding causes rapid activation of the coagulation pathway, so there's a blood clot formation initially. Within 24 hours neutrophils will be seen. Okay, within 24 to 40 hours, epithelial cells from both the edges will begin to migrate and proliferate towards the center. By day 3, the neutrophils will be replaced by the macrophages and granulation tissue will now start to form. All these days are very, very important. Okay, this timeline is important. By day 5, you have neovascularization, which reaches its peak. New vessels are formed, but these new vessels are initially leaky. Okay, and because initially leaky, allowing the passage of plasma proteins, and therefore the new granulation tissue which is formed, it is edematous. Okay, and then towards the second week, you have this continuous collagen accumulation and fibroblast proliferation. By the end of the first month, the scar comprises of a cellular connective tissue largely devoid of inflammatory cells and covered by an essentially normal epidermis. Okay, this is the healing by the first intention. Please draw these diagrams in your exam. And in the second intention, what happens is that whenever there's a very large defect, then there's healing by second intention. The inflammation is more intense here, and there's a much larger amount of granulation tissue which is formed here. A provisional matrix is formed containing fibrin, plasma, fibronectin, type 3 collagen. Okay, because this is again replaced by type 1 collagen. The wound contraction occurs here, which help to close the wound by decreasing the gap. The wound contraction involve formation of a network of myofibroblasts. Within 6 weeks, the large skin defect may be reduced to 5 to 10% of the original size, and the tensile strength results from the excessive collagen synthesis and the cross-linking of the collagen. The wound strength will reach 70 to 80% of normal by 3 months. Again, a very important point. Okay. Defects can always be there, like venous ulcer, arterial ulcer, then pressure sores, and diabetic ulcers. If this, what is this point which is excessive scarring? There can be some defects in the scarring process. So excessive formation of these components of the repair process will give rise to something called as a hypertrophic scar and the keloids. You will read about this in surgery. Now, but I'm going to mention over here that when you talk about the hypertrophic scar, it is because of the excessive amount of collagen deposition. Okay, these grow rapidly. There is abundant myofibroblast. That is why there is abundant collagen, and this happens in hypertrophic scars and not in keloid. What happens in keloid is that the scar tissue grows beyond the boundaries of the original wound. So this is the wound, the scar tissue will grow here and here and here. Okay, it will not regress, it will keep growing beyond the boundaries. This is called the keloid. In hypertrophy scars, the boundary is maintained. Inside the boundary, there will be more production and more deposition of collagen. It will be a thick scar, but keloid में क्या होता है कि boundary से भी बाहर निकल के चला जाता है. ठीक है. This involves the deep layers of the dermis. So I hope that this is something which is not much important. So I hope that this makes sense, and this is how we come to the end of this chapter. This was a long chapter, but again it is not that difficult. So that in acute inflammation में जितने भी steps मैंने discuss किया है, that is the most important and difficult part. All the molecules are very, very important. In the chronic inflammation, obviously this healing, first intention, second intention, all these things are important. So if you have any personal query, you can mention down in the comment section below. I will come very soon with the next episode of this Read Robbins with Me series. And if you enjoy watching this, then please give your valuable feedback and inputs so that I can improve on my work. I will meet you very soon in my next video. So till then, take care, keep studying, and thank you for watching.